Hello, friends. Today I'm going to talk to you regarding the latest classification of odontogenic lesions. Incidentally, the cysts tumors make a greater bulk of pathology. Along with inflammation, we are very sure that a pathologist can be a great person if he knows all these aspects of lesions. Now, odontogenic lesions have been of great interest to everyone ever since the classification that was done, as far as by people like Ronches and even Greggs and these people who did the work in the past had emphasized that there is a difference of various lesions associated with the germinal layers, whether it's ectoderm or whether it's mesenchyme or mixed. So the present day classifications arose from these three basic aspects of ectodermal or mesenchymal, or it could be mixed tumors also. Now, today I am going to give you a resume of various lesions that are associated and how the classifications arose and how we are trying to describe them in the future, because the changes had taken place as far as the beginning of 1971 when the two lesions were classified. Eventually, again in 1992, the classifications were made. Then in the third stage, there was a changes made in 2005, and subsequently the last interpretation was done in 2017. So I'm going to give you a variety of changes that has occurred during these past years, and then what is relevant today we are going to try to describe to you. Thank you. As I was telling you, today we are going to talk to the topic of odontogenic tumors and cysts revisited. Incidentally, we are aware of the fact that cyst is a closed pathological cavity which is filled with either fluid, gas, or even air, or even solids. Now, incidentally, cysts were classified as odontogenic cysts and non-odontogenic cysts as a matter of fact, and therefore the odontogenic cysts were further classified as developmental and inflammatory. The inflammatory cysts included the radicular cysts, which is usually also called as apical cysts, and inflammatory collateral cysts. The calcifying odontogenic cysts, which were once upon a time called as Gorlin's lesion or Gorlin cyst, represented a heterogeneous group of lesions that exhibited a variety of clinical, behavioral, and histological features. Of course, today the calcifying odontogenic cyst is now classified by WHO as a tumor. The calcifying cystic odontogenic tumor, which is also called as CCOT, is now an odontogenic cyst which is associated with even ameloblastoma. Now, regarding the odontogenic tumors, it is described as heterogeneous group of lesions of diverse clinical behavior and histopathological types, ranging from hamartomatous lesions to malignancy. Now, as a matter of fact, we have got two varieties of lesions, which we call it as benign odontogenic tumors and malignant odontogenic tumors. The benign odontogenic tumors comprise of epithelial odontogenic tumors. It could be mesenchymal of origin or even mixed odontogenic tumors, as I had described to you earlier. The WHO classification of odontogenic tumors, which is still valid today, was based in 1971, who WHO classified as number 1, ameloblastoma, calcifying epithelial odontogenic tumor, and squamous odontogenic tumor which are epithelial in origin. Historically, the WHO benign odontogenic tumors classification from 1971 to 2017 is almost the same. While the odontogenic carcinomas or odontogenic malignant tumors were described under the headings of malignant ameloblastoma, primary intraosseous carcinoma, the other carcinoma arising from odontogenic epithelium, which includes those arising from the cysts as well. The odontogenic sarcomas, which are of connective tissue origin, comprised of ameloblastic sarcoma, ameloblastic fibrosarcoma, also called as, and the ameloblastic odontosarcoma. Finally, the odontogenic carcinoma were described to be as a malignant variety, described as malignant ameloblastoma, the primary intraosseous carcinoma, and malignant variants of other odontogenic epithelial tumors. In 1992, once again, there was a need for a change for classification, and they described that the malignant changes in odontogenic cysts or odontogenic sarcomas were comprising of ameloblastic fibrosarcoma, also called as ameloblastic sarcomas, and ameloblastic fibrodentinoma. Fibrodentinoma is also described as fibroodontosarcoma. The WHO classification in 2005 further says that odontogenic carcinomas could be metastatizing ameloblastoma, which is malignant in nature, the ameloblastic carcinoma, and ameloblastic carcinoma secondary to of intraosseous type. The WHO classification in 2005 described that ameloblastic carcinoma of secondary type is a peripheral in origin. The primary intraosseous squamous cell carcinoma derived from keratosis is also called as odontogenic tumor, which was earlier described as odontogenic keratocyst. Now it's described as primary intraosseous squamous cell carcinoma derived from keratocyst odontogenic tumor. Thirdly, you find that primary intraosseous squamous cell carcinoma, which could be of a solid type. The WHO classification regarding the primary intraosseous squamous cell carcinoma from odontogenic cysts, especially the odontogenic keratocysts, were described recently. The clear cell odontogenic carcinoma and the ghost cell odontogenic carcinoma was also described. In 2017, the latest one, the modifications were done in such a way that odontogenic carcinomas comprised of ameloblastic carcinoma, primary intraosseous carcinoma, and sclerosing odontogenic type of carcinoma. Finally, the clear cell odontogenic carcinoma, ghost cell odontogenic carcinoma, and odontogenic carcinosarcoma and odontogenic sarcomas were described in 2017. However, the connective tissue tumors were described in the malignant form as ameloblastic fibrosarcoma, ameloblastic fibroodontosarcoma. The changes that have taken place in 2017 from the previous ones of 2005 and 1992 were that the keratogenic KCOT has been reverted back to OKC, whereas the calcifying COT has been reverted back to COC. The desmoplastic ameloblastoma became a separate entity. The ameloblastic fibrodentinosarcoma and fibroodontosarcoma has been eliminated. So these are the various changes that are taking place in the recent classifications. And just now, as I am going to talk to you further, I will be dealing with a few of the lesions which are very prominent and which could be of useful to all of us. Now you can see a beautiful lesion that is present in the third molar region where there is an edentulous, where there is a impacted third molar tooth which has led to the dentigerous cyst formation involving the body of the mandible and of course the ramus as well. You can see the beautiful lining of stratified squamous epithelium and showing the border of the cyst wall. At the same time, you will find the presence of darkly stained, rounded oval bodies in the connective tissue, which we called as Rushton bodies. Here is again a section of the odontogenic cyst, that is the dentigerous cyst, and you can find the cystic wall beautifully lined by stratified squamous epithelium with a empty space which was once upon a time present in containing cholesterol crystals. Now here is again a ramification of the epithelial cells which has taken place as a result of infection, and that has shown the linear pattern of the epithelial cells here as in the dentigerous cyst. Again, you can see a beautiful lining of the epithelial wall of the cyst. Once again, the epithelial wall is shown nicely. The apical periodontal cyst is as a result of infection brought about due to periapical pathology, due to dental caries which has progressed further and leading to the formation of a cyst which is present in the apical portion of the tooth. Now, you can find the lesion which is very much symmetrical in nature and which is present apical to the infected tooth, and you can find the dental caries which is the root cause for this apical lesion. You can see the stratified squamous epithelium so nicely proliferating in the cyst wall, and you can find that there is present the cystic fluid that is supposed to be cholesterol in nature, and these cholesterol crystals have been stained in such a way that you will get it in the form of glistening pattern, and that's how it is represented. Again, you will find that the epithelial cells proliferation has taken place here in this area, and you can find there is a red network which is supposed to be as associated with the radicular cyst. The apical pathology which is associated with the proliferation of periapical tissues, and you will find there is presence of stratified squamous epithelium. Again, you can find the presence of beautiful Rushton bodies that are present in the cystic cavity and in the connective tissue which is associated with the irritation. It's a beautiful, you can see how well they are depicted in the picture, and these are classic of the Rushton bodies which are formed as a result of response of the connective tissue to the presence of this. Now, odontogenic keratocyst is supposed to be once upon a time a odontogenic cyst. Today, now it is classified in the form of tumor. Now, you can see the stratified squamous epithelium. We have got the basal cells which is palisading in nature. You got a corrugated epithelium, and you can find there is hardly any inflammatory cells present in the connective tissue. Same way, again, it is represented here. You can see the presence of connective tissue and epithelial junction, which is hardly showing any inflammatory cells. The primordial cyst, supposed to be of developmental nature, you can find it as an incisive canal cyst, or it could be in the form of globulomaxillary cyst, or it could be in the form of any other type of cyst. Now, here is a lesion which is supposed to be present in the maxillary area, and you can find it present in a large involvement. This is a globulomaxillary cyst which is supposed to be very much prominently present in the form of inverted pear-shaped and present between the lateral incisor and the canine. The calcifying epithelial odontogenic cyst, or CEOT as it is described, supposed to be a lesion which is present usually in the anterior region and affecting the maxilla rather than the mandible. Now you can see the presence of the classic ghost cells, and can presence of the presence of inflammatory cells. At the same time, you will find there's a proliferation of the epithelium also. This is under the a special staining technique where we have used a special stain to describe the presence of the ghost cells as well. Another lesion which you can see here, which is in a radiograph and shows the presence of lesion in the premolar and molar area. The CEOC showing carcinomatous changes. Now here you can see the CEOC, which is supposed to be a normal lesion, of course, has become more malignant, and can see the presence of the darkly stained pycnotic nucleus and presence of mitotic figures, a characteristic of carcinomatous changes. Adenoameloblastoma. Usually the lesion is present in the anterior region, and more commonly the females are affected than the male, and you can find these lesions are supposed to be affecting the premaxillary segment, and you can notice the presence of large number of the Rushton bodies, and you can also see the presence of epithelial cells, which is in a stratified squamous epithelium. The cystic lesion, which is supposed to be glandular in nature, you can see that, and you can see the presence of alveoli also. Now this is ameloblastoma, which is characterized by presence of columnar cells, tall columnar cells, which is supposed to be present in the form of a circular pattern. Here is again a picture of the same, and you can notice the adenoblastoma present to be in the premolar canine area. Calcifying epithelial odontogenic tumor, also called as Pinberg's tumor. You can see the darkly stained nucleus that is present, and you can see the presence of these ghost cells, and you can find out the presence of hardly any inflammatory cells there. Some special stain. You can see the multiple nuclei that is present here. Okay. And the last but not the least is the thyroglossal cyst, which I am trying to show you. Supposed to be present in the neck region, and supposed to be a lesion that is found as a result of the descendants of the thyroglossal duct, and you will find the lesion present in the neck region, and this lesion could be of a non-odontogenic origin in nature, and you can see there's a beautiful lining of the epithelium, which is supposed to be pseudo-stratified ciliated squamous epithelium, and your presence of this lining is present. At the same time, you will find there is presence of a large number of cystic walls also present, which contains the homogeneous or presence of thyroid products.